Good afternoon, everyone, and welcome for these sessions that our CME today will talk about the topic that will come. It's called sleep capital femoral epiphysis, known by the SCEFI, or the other name is SUPI, sleep upper femoral epiphysis. And I think we'll have Dr. Cyril will take us through the sessions. Cyril is a third-year orthopedic resident based in Tenwek. He's under training of PACS. PACS is Pan-African Academy of Christian Surgeons and affiliated by Loma Linda University. And he's also involved in COSEXA, College of Surgeons of East and Central Africa. So he'll take us through it. We will have Q&A that kindly send your questions through the chat box so that we'll be able to read it and we'll answer accordingly. This session will have a CPD point. So each and everyone that able to attend this CME will be able to get a CPD point. There will be also a survey in the end of the sessions. We'd like each and every one of you to be able to fill it out and so that we can be able to grow and progress in this. So my name is Fasto Yugusuk. I'm one of the orthopedic surgeons here in Kiwa. Kiwa is one of the pediatric hospital. Here is based in Kijabi. And I think in this moment, I would like to welcome Cyril. You can take us through.
Okay. Thank you for that. Let me first of all start my screen share. I hope everyone can see the screen.
We can't see your screen yet.
Okay. I think now it's visible.
Yes, it is.
Yep. So as Dr. Fast said earlier today, we are going to be discussing about sleep capital femoral epiphysis. Dr. Cyril Oike, third-year orthopedic resident. I'd like to appreciate Dr. Eva Langat, who did prepare this presentation, but she's currently not able to share with us this presentation. So we'll start with a couple of case presentations, which I think will come later on in our discussions. So the first case, we have a patient CW, 13 years old male, 67 kgs, presented with a 1 month history of right hip pain preceded by trauma. It was a biking accident and had an acute onset left hip pain a few days prior to presentation. Ambulant with crutches, has bilateral groin tenderness, external rotation and hip flexion, reduced internal rotation, and he was noted to have a shortening of about 1.5 centimeters with the X-ray displayed there at the side. We'll discuss about this case later. And in the second case, JM, 14 years male, presented with a 1 year history of right hip pain, acute exacerbation 2 days prior to admission following a fall. He's currently unable to ambulate. On examination, hip tenderness, external rotation of the hip and knee flexion, and has limited internal rotation. Noted to have a shortened right limb with the X-ray displayed there. On the third case, MS, 13-year-old male, 70 kilos, 1-year history of progressive worsening left hip pain with having a limping gait. Noted to have a shortening and a reduced hip motion on the same side in external rotation, but could not tolerate a further hip examination at the time of presentation. And his x-rays basically displayed there. Yeah. I think these cases will come back to them, but we should keep in mind about them. So to start with, what is SCIFI? Basically, SCIFI is just a condition where you have a proximal femoral physis slipping relative. So basically, it's the metaphysis slipping relative to the epiphysis along the physis. Of importance to note is that the epiphysis remains in its congruency with the acetabula. It's only the metaphysis which is the one which is slipping, mainly along the either anterior and superior movement. It's mainly because of a weakness in the perichondral ring, and the slip mainly happens at the hypertrophic zone of the physis, as we do know the zones of the physis, which we'll discuss about them, but it's the weakness which is happening at the hypertrophic zone of the physis. For the epidemiology of the condition, mainly it presents in male patients, has a basically a male preponderance, more in a ratio of 2:1, and mainly we see it in adolescents, 10 to 16 years. This is when there's rapid growth predisposing to having that slippage. Seen more in the blacks as compared to whites when you compare to races. Obesity, it's really a factor in it, as you'll also see it in the risk factor and also the pathophysiology of it. And it's been noted it's mainly on the left hip more than the right hip, with 25% of it being bilateral. Of importance to note is that the second slip usually happens 12 to 18 months after the first slip, which we'll discuss about it. For the risk factors of it, obesity, as I stated earlier, it's the single greatest risk factor causing SCIFI to happen. Radiation therapy to the femoral head is basically this is predisposing the physis to some element of weakness, causing it to slip. Endocrinopathies, especially hypothyroidism, hypopituitarism, renal osteodystrophy, and growth hormone deficiency, noted to be a risk factor for developing. Femoral and acetabular retroversion, this mainly increases the shear forces which act to the physis, so basically predisposing the patient to having a SCIFI. Genetics, if basically family history of SCIFI predisposes a patient to also have it. Any inflammatory condition, patients with Down syndrome, and also seasonal variations. Basically, this is based on papers written from the West that during summertime, they tend to have more SCIFI, and it's more of the activity level at that moment. Of importance to note on the pathophysiology of SCIFI, it's basically a multifactorial thing, which is other factors acting upon a weakened physis. So we are having a susceptible physis due to perichondral ring weakness, predisposed because of the age at that time, or even radiation exposure, which causes a weakness of the physis. So the weakened physis now with external factors such as obesity, which induces stress at the growth plate, are also having a growth spurt. That's why it's common between the ages of 10 and 16 when patients do have a growth spurt. So all these external factors with the factor of having a weakened physis causes the physal separation now presented with a SCIFI. And as we stated earlier, the epiphysis still remains at the acetabula. It's well situated at the acetabula as compared to which the metaphysis which now displaces anteriorly and externally. It's important to note that the importance of how the epiphysis still remains at the acetabular, considering the other fractures which can happen along the physis, but now the epiphysis will be out, and that will not be classified as a SCIFI at that moment. So for the presentation, for the symptoms, they do tend to present with growing pain. That's mainly because of radiation from the reflex arc involving the somatic sensory nerve endings, that level. Thigh pain, also knee pain. Of importance to remember is that any patient within those the age of 10 to 16 presenting with a vague knee pain, it's important to rule out SCIFI, because this is one of the reasons why SCIFI is really missed in a majority of the population, because they tend to present with the knee pain, but it's just a referred pain because of the obturator nerve radiation. They have also a limping gait, an antalgic gait because of the pain, and the foot has an external rotation. This is basically based because of the rotation, the slipping of the metaphysis, which slips basically anteriorly and superiorly. Sit with the affected lip crossed over the other, basically to try and reduce the pressure. And it's important to note the duration of symptoms, as we'll discuss later, the importance of noting the duration of symptoms in terms of chronicity of it. For the signs, they have this obligatory external rotation on passive hip flexion. They have reduced internal rotation, flexion, and abduction. Have this abdominal gait mainly because of the pain, trying to relieve pain on the affected limb. If it's a long-standing pain, they'll tend to have thigh atrophy, and also limb shortening can be noted in this patient. It's important as you're examining these patients that you should be thinking about, is it a stable SCIFI or an unstable SCIFI because of the risk of damage to the retinacular vessels in these patients. So for the imaging, your imaging modality will be an AP view and also a frog lateral. For patients who have unstable SCIFI and you really can't move their hips, you can do a cross-table lateral view, basically to see the posterior extent of the slip according to that view. So for your AP view, you want to check your knee Klein's line. This is a line which it's from the superior aspect. So a line drawn from the superior aspect bisecting the epiphysis. So in a patient who has SCIFI, it will tend to not bisect the epiphysis once you draw that line. There was a variation of this Klein's line, which was done basically to try and improve the sensitivity of the Klein's line in patients who have really subtle slips, mainly grade 1 slips. You can't visualize. We draw a Klein line and you'll see that it is really crossing, it's transecting the epiphysis. But another factor you can use it's to draw the Klein's line on both sides, the affected hip and then an unaffected hip, and then the largest lateral distance from the Klein's line of the epiphysis. You check the difference with the contralateral hip. If it's more than 2 millimeters, the chances of a SCIFI are high on that hip. This increased the sensitivity of Klein's line, be able to detect SCIFI in these patients. Frog lateral position can be used to check also for subtle slips and also posterior displacement in these patients, as seen in these images of A and B, how to basically place the patient as you are planning to take a frog lateral X-ray. Cross table, as I stated earlier, you take it to just take the posterior extent, and this is an unstable SCIFI, whereby you really don't want to do any much maneuvers to injure the retinacular vessels. A CT scan can be done for a SCIFI, but they are mainly for pre-op plannings. If you planning to do complex osteotomies, these are basically you're planning to do an osteotomy just to hold to prevent further progression of the SCIFI. So they're not really used for diagnosing of a SCIFI, but you can use them for just to plan for your need for the osteotomies, and also can be used to determine closure of the physis in these patients. So sometimes in some patients, they'll tend to present with the classical signs of SCIFI, but on X-ray, you can't see, there's no radiological evidence of them having SCIFI. In these patients, basically subtle slips, you'll tend to do an MRI, which will show you periphyseal edema, basically like an early sign of SCIFI in these patients. It's also important before you plan on your management of these patients to think about the classification of the SCIFIs. So one of the classification we tend to use the temporal classification. This now divides us from acute, between acute and chronic. Acute being less than 3 weeks, chronic being more than 3 weeks. But we have this subset, acute and chronic, which is basically patients who are having this chronic hip pain more than 3 weeks, but then now present with an acute in an acute setting of pain. The one which has been widely accepted, basically we tend to use in terms of conversation about SCIFI, it's the Loader classification. This now you're classifying based on stability, if they are stable or unstable. And the factor that determines stability is weight bearing. Are they able to weight bear? If they're able to weight bear with or without crutches, that's a stable SCIFI. But if they are not able to weight bear, a patient comes in a wheelchair, in a gurney, those you classify as unstable SCIFI. You can also use the Southwick angle. This is basically a metaphysial angle, just to check on the slippage. So it's a line perpendicular to the physis, and then checking on the shaft. So basically it's a neck shaft angle with the neckline being perpendicular to the physis. Normally you'll get at 145, but 130 may be predisposing to other SCIFI. And also on a frog lateral, you'll still use that line, basically perpendicular to the physis and the shaft, basically having the neck shaft angle. So it's important to realize if you're having bilateral involvement, basically a patient who presents with bilateral SCIFIs, you'll use 145 degrees on AP and 10 degrees on lateral as your reference point in this patient if you're wanting to classify them based on their Southwick angle. So a difference of about 30 degrees, that's mild, moderate 30 to 50, with severe being above 50 degrees. For the grading system, this basically you use this system. It's it's mainly used for preoperative planning, as you're planning where you'll place your in situ pinning as you're fixing. So 0 to 33, grade 1, it's 0 to 33 slippage, basically a third. 34 to 50 slippage, that's grade 2 and above 50% of slippage. It's now grade 3. But this, you'll tend to use it to help you in inter-op management, as opposed to using this system for communication to fellow doctors. So for treatment, our goals are basically, we want to prevent additional slippage from the epiphysis, stimulate early physical closure so that at least you don't have the damage to the physis, avoid chondrolysis, osteonecrosis, and osteoarthritis in the future, and to restore the biomechanics of the hip. So the restoration of biomechanics of the hip and prevention of complications is somewhat a hard had procedures to be done, but to prevent additional slippage and basically stimulating fascial closure, those are easy maneuvers which you do with the other op management of the condition. So for the management, as in OPO, we divide it in non-op and operative management. So for the non-op management, basically this was a historical way of managing skiffle, basically traction with a hip spiker to prevent further slippage, but it never prevented complications associated with skiffle, AVN being top of them. So this was abandoned, and it's currently not well anywhere practiced non-op management. So for the operative management, you can do in situ pinning. This is what you do for stable slips. You can use a single cannula screw perpendicular to the physis, but research has shown even if it's oblique to the physis, there's not much of concern in terms of even when it's oblique, it can still prevent slippage. The reason why you may tend to go oblique to the physis is if you're trying to prevent impingement, because as you're placing the screw, you'll tend to want to be center on it, and in the aim of being center on it, you may tend to place it along the femoral neck, and that may cause an impingement. So you can also go slightly oblique to it if you are able to at least prevent the impingement. And the way of basically helping you not to have that impingement on the femoral neck, it's make sure that your entry point is lateral to the intertrochanteric line, because that really helps not to have the impingement. Some literature says 5 threads across the physis. It's really important because it decreases the rate, the progression of slippage. They're showing less than 5 progression to slippage comes to about even 47%. And at 5, the progression to slippage is close to even 0%. But of importance, you have to make sure that you don't cross you don't cross the head, basically impinging towards the acetabula. One screw or 2 screw, it's being shown. One screw, it's basically sufficient, stable for these patients, and 2 screws. The problem with 2 screws increases the risk of AVN, but there are some times we may have to basically place 2 screws. And that's basically in patients who have unstable skiffles, who after even the reduction, you tend to still have, you have already done your pinning, but there's an element of slippage in it. In some displaced skiffles, you may do a close reduction with pinning. It's been noted even just the action of placing the patient on the table may reduce the fracture. But you can also you may be forced to do a leadbetter loader shoulder technique, basically for the abduction, flexion, internal rotation, adduction, and extension, as you're trying to reduce. But you tend to want to be not aggressive with this, because you may inadvertently damage the retinacular vessel, predisposing the patient to having an AVN. It's another simple maneuver. You can also do an inline traction with slight internal rotation, which has been shown also to slightly reduce, because the displacement is superior and anterior. So if you do that maneuver, you're just basically countering that displacement. It's noted that in severe slips and also unstable slips, there's a high risk of AVN. And in some centers, they can do even perfusion monitoring with an A-line, basically intra-op, trying to see is there perfusion to the epiphysis after the reduction. After that, you may do also a percutaneous capsulotomy. This is basically to decompress the intra-articular hematoma which had formed with the slippage and the damage to the retinacular vessels. Important thing to note also is after you're done with your pinning, you have to really check that you have not penetrated the head going towards basically the hip joint and the acetabulum. Because complications of screw penetration will predispose patients to having joint sepsis. They can also have a focal acetabular erosion, synovitis, post-hip pain, chondrolysis, and late degenerative osteoarthritis because of that damage. So it's mentioned the pin that you do use if you're using the cannulated screws to place to do the skiffy. Its penetration will not really cause the chondrolysis, but now the screw itself, if it penetrates, it will cause chondrolysis. One of the ways you can check if you have screw penetration, you can do the approach withdrawal technique, whereby still under C-arm, you range the hip in different, basically different planes. With this, you're trying to see in all the planes, is there anywhere that you are having a screw penetration? Another maneuver, you can inject dye. If you use the cannulated screw, injecting dye through the cannulated screw, and just to see if there's any dye extravasation into the joint. If it shows that, then it's basically a mark that you have penetrated the joint, and you really have to revise it. You don't leave the patient with that. Another way of managing, especially if they do have these unstable skiffes, which are markedly displaced and all the maneuvers are not possible, you can do surgical dislocation, capital realignment, and fixation, basically a modified DAN procedure. This is for acute proximal femoral deformity. The main aim of this procedure is you're trying to preserve the epiphyseal blood supply and also now the stability after you've now placed your reduction pins. The complication rate, it's like 37%, reduces AVN from ranges of 47% to 26%, but it's quite tedious surgery with a steep learning curve for it. But it's really helpful in terms of locating these patients. Another maneuver you can also do is just an anterior approach to the hip, open up the capsule and try with your finger to reduce the epiphysis to the metaphysis, and then you can pin, especially if all the reduction maneuvers are not working for these patients. So basically, a summary of all the procedures we have discussed in this session. Another important aspect is when do you do contralateral prophylactic pinning in these patients? So any patient who's presenting with atypical skiffy, we talked about the risk factors because this, I think in my center we have seen it, whereby a patient presents, he's slender, he's 10 years old, female patient, and has skiffy. No factors basically clicking. These are atypical skiffies, so you tend to predispose to having a prophylactic pinning. Female patients below 10, male patients below 12 years, also do a prophylactic pinning. Patients with an open triradiate cartilage, like you can see in this X-ray, basically having an open triradiate cartilage, they tend to have skiffy on the contralateral side, which we said 12 to 18 months later. Patient with any endocrinopathies and also a posterior sloping angle of more than 12 degrees. Now, the sloping angle, basically, it's a line, it's an angle which you measure. So line A, it's usually a femoral neck diaphysis angle. And then line B, it's aligned along the physis. And then line C, it's aligned perpendicular to line A. Now, that angle which you form, that small a, that is the sloping angle. If you measure a sloping angle of more than 12 degrees on the contralateral hip, it's encouraged to do a prophylactic pinning for these patients, just to prevent them from having a slip in later days. So for the post-op mobilization, a patient who presents to you with stable sleep, you'll do in situ pinning, and then they can have weight bearing as tolerated after surgery. You'll tend to start all of them on hip range of motion after surgery, but for this to have stable sleeps, they can start on weight bearing as tolerated. If they have unstable sleeps and you did a close reduction in pinning, touchdown weight bearing for 6 weeks, and also patients who had a modified DAN procedure done because of not being able to reduce it in a closed fashion, touchdown weight bearing for 6 weeks. Complications, osteonecrosis, really, if it's, especially for unstable sleeps, they can predispose to osteonecrosis, and also iatrogenic. Patients who are presenting in casualty and you're aggressive in terms of examining them and they do have an unstable sleep, or you're trying to take a frog lateral x-ray, you may cause an osteonecrosis for them. Contralateral skiffy, as we've discussed, chondrolysis because of nail penetration, residual proximal femur deformity and shortening. Basically, they tend to have femoral acetabular impingement, which later predisposes them to having early osteoarthritis. Sleep progression, especially if they needed 2 pins and you give them 1 pin. Infection, degenerative arthritis, pin-related fracture, labral tearing and degeneration. This is like if you're thinking about placing of a second screw placement, it may predispose to that. And also delayed diagnosis, which I stated earlier, because of patients who are presented with knee pain, and people don't tend to basically follow it up and see if there's any pathology on the knee. Yeah. So on our first case, CW, so has this 1 month history of right hip pain preceded by trauma, and then an acute onset of left hip pain. So on this patient, I think we may classify him as having chronic factor because of the 1 month, and then now acute onset, few days. This is less than 3 weeks. So this patient who is presented with an acute and chronic skiffy for them. They are ambulant with crutches. That's another factor to see that basically they are having a stable skiffy on presentation. Yeah. On our second case, 1 year history of right hip pain. That shows you the chronicity. It's not acute, more than 3 weeks. Unable to ambulate, exacerbation in 2 days, that's the acute factor. So an acute and chronic presentation, unable to ambulate, they're having an unstable skiffy for this patient. And then on the third case, 1 year history of progressively worsening left hip pain, limping, shortening and reduced hip motion. So this is a patient presenting with chronic hip pain. Did not tolerate further hip examinations. This tend to be patients with an unstable skiffy. So for the first patient, we're able to do in situ pinning. And basically, that's the post-op X-ray. And then for the second patient, JM, also we did an in-situ pinning, the post-op X-ray. And for the third patient, also in-situ pinning, post-op X-ray. Okay, thank you.
Thank you, Cyril. This is a very elaborate presentation. This is sessions we'd like to welcome all the questions that should come, putting in mind that this is one of the commonest conditions that's really happening in either adolescents or in adult. And it's either one of your patients outside there or it's one of your brother. So my big term here will be really the main reason for this presentation is timely diagnosis so that we avoid any delay. And we can see from the presentation that our 3 patients all were delayed in presentations, putting in mind that they may presented with a very different kind of presentation with the knee pains or something is not very focused. And most of us who outside there is not well equipped with the condition of the children in these conditions, they may just tend to think, oh, maybe something different. And this has led to the delay of diagnosis. This delay of diagnosis, of course, have a risk factors. And we know that every time that it's become more delayed, the risk of the osteonecrosis become very high. And also the second thing is that the slippage become more aggressive and become progressing. So it's end up with more impingement, end up with more deformity of the proximal femur, which is we need more now complex kind of the surgery, like, you know, we need some kind of the osteotomies in that situation. If there's any questions, kindly, we will be happy to answer. Currently, we are not seeing any questions, but I would like to mention to the audience outside there that we are dealing with the hypertrophic zone, and if you go back to your basic science and you remember about the extracellular matrix, we are dealing here with the type 1 collagen, and in type 1 collagen, of course, in this area here, there's many different books will talk about hypertrophic zone by itself alone, and some books will talk about it's actually combination of the proliferative zone and hypertrophic zone. So it's like, you know, it's just in that area there, putting in mind that this is the avascular area. This area here between the proliferative zone and the hypertrophic zone, this is the avascular area. And if you go back to your anatomy, you remember that the blood supply to this area is like you have a 3 type of the blood supply. This blood supply go to secondary ossification center, which is epiphysis, and it will end up giving, it's not penetrating the proliferative zone, but it's giving high area, and this is why we call it the area of the high oxygen tensions in this area here. The calcium in this area, the same like in an epiphysis or in the proliferate in the epiphysis area, but it's not calcified. So this is not calcified calcium in this area here compared to epiphysis, where it's not tended to increase the height or the length or the longitudinal growth. Putting in mind also, you know that the cartilage arrangement in this area is different. So the blood supply that in this area is the one that coming through the epiphyseal artery, and then you have the nutrient artery that coming all the way from the medullary canal. So again, where exactly do you place the screw? Near the calca or in the center of the neck? Great, that's a very good question there. The question coming from from Peter. So I would like to give you a very few trick that me myself I use. So surgical wise, this case can be very short in the very skilled hands or can be very long in unskilled hands. And this is what I do. I usually draw the lines, like I would put the patients in the traction tables, and I would draw the lines, and in my line would go like this. I like to put them systematically. There will be a single line perpendicular to the center of the physis. That's mean the AP. You have to have the AP X-rays, lateral X-rays with your C-arm, and then you will have line number 2 in the intersection of the screw or guide wire. That's in the skin. That's in that relative plane. Then the placement of the guide on the anterior thigh. So when you put that guide on the anterior thigh, that will directly direct you when you're taking the C-arm also in that place. Then anterior posterior fluoroscopic image you require in this position, because you want to see really that you are in the neck and you're perpendicular. You are in, the aim here, of course, you are aiming for the physis, that you have to be in the center of the physis. And then you also place a guide wire on the lateral thigh. So you have anterior, then lateral side dissection of these two wires. You draw the line with you. You should have to have a marker pen on your table, and you draw them, and that will give you the point where you can actually have your stabbing wound. Because if you're not very precise and you did not really carry this process as I'm describing, you will end up either with big wound or multiple stab wounds, which is will really not the intent that you want to do from the beginning, because this is one of the surgery that is very minimally invasive. Lateral fluoroscopic images is very important, and then intersection of the planes of A and B, which is, I say, the single line perpendicular to the center of the physis, and then the intersection of the screw or guide wire in the skin plane. And that's at that area, that is where you can actually be able to insert the guide wire at the intersections of these two planes between the A and B. And that area by itself, you should be able, every time your slip is more, the percentage of the slippage is more, you attend to more coming more anterior to the neck. If the slip is no more slippage, and this is condition of a little bit in that chronic stage, so you find yourself, you actually putting your pins more from the lateral at the side of the trochanteric area, and you're out away from the neck. What I realized myself, if you're actually dealing with the very acute slip, acute on chronic, of course, acute on chronic, most of the time they don't reduce. Even if you're trying to put them in the table and you do the maneuvers, they don't reduce, and you don't need to pause them. So you're supposed to just in situ, as it said, you don't tend to do aggressive reduction, and you pin it in that position. But if it is, you catch it very early, and that is our intention for this purpose of this CME, that you should be able to catch this kind of the slippage very early. And if you catch it early, it's a little bit challenging, because when you start from the lateral position, it's a little bit gliding, and it's very challenging to go all the way through. But that's based on how experienced you are and how can you put your line that you directed in that position. And I think that will be very, very key point there, that when you're able to put your screw in the right position. We'll encourage people to ask more questions. As you can see, based on the epidemiology, this is one of the commonest conditions. Either you can say it 1 per 100 or 10 per 100,000, or you can say 0.2 in the 10 patients. So it's common, and it's outside there. Actually, what we're seeing in Africa is different compared to the one that's been seen in the first world. I was in Tenwek, and I'm also here currently in Kiba. We see children with very skinny. Their weight is not like the commonest one being described in the book. So we really need to work up about the endocrine conditions, because our patient is not fitting in like what is really being said in the Western literature. So I would like to encourage us that let's do more workup. And my encouragement will go even to the people, either you are caught outside there in the sport, So you should be able to elicit if any kid coming with you, you know, you have thigh pain or knee pain, you should be able to refer this person to the right place. Or if you also dealing with you're in the school, you're a teacher, and you know, you have a kid that's complaining with this kind of the vague symptoms, you should be able to refer them to the right place. Again, I would like to emphasize that early diagnosis is a key to avoid the further complications. And the complications are many. And most of it, of course, is very devastating. There's many papers outside there that showing that most of the people have early hip replacement. Initially, they were missed kind of the slip capital femoral epiphysis. They did not been treated in the right time. So now they're presenting later on with the osteonecrosis and also arthritis, which is now can be prevented. Any child who present with the knee pain and after examination you find no problem, always examine the hip. Have any encountered many children who are not overweight? Yes, of course, George, that is a very, very, very good point there, that if any child that have a knee or thigh problem, examine the hip, and you better have negative result than actually to miss. Say, you know, there's maybe nothing and you miss this patient. It's better to do the examination. Me myself, Dr. Faso, I have encountered like 5 patients that they're very not chronological to the weight that is being put outside there. Kids are very small weight, and they have a slip capital femoral epiphysis. If there's no more questions, I would like to take us back to the point, when do you do twist screws? So twist screws, literature put it very clear that actually in unstable slip capital femoral epiphysis, you should be able to put twist screws. The point is, how do you put them? That is very, very important point here, that you need really to know how you can put this screw, because there's two positions that you should avoid. You should avoid to put this screw superiorly or inferiorly. These 2 positions, you should not put these screws that you're adding on it. So if you have to put a screw, you should put it at the medial or lateral to the neck. And that's, of course, based on your guide, and you draw your direction very well that you can be able to put. These patients, after the fixations, they tend to have still discomfort, because the impingement that happened in the labrum, you did not take care of them, and they already have degeneration there. So they will still have this kind of the pain and discomfort that they have. But we encourage them to do more physiotherapy. Range of motion is very, very important, because as all of us, or most of us know, that joint always get the nutrient supply through the motions, because there's no direct blood supply to the cartilage. And by the slippage and around of inflammatory process that's happening, that will make it a little bit more less motion, because guarding and pain, but encouragement of this patient to really do range of motions is very important. Not aggressive, but it should be very, very gentle kind of range of motion. We'll encourage still people to put question outside there, and I think we should be able to have our survey. So we see we can see that the appreciation about the presentation, there's most of the people up to 62%. That's a good. We will encourage this kind of the CMEs to be continuing sessions. There will be, of course, we mentioned there will be a CPD. Kindly still, you can still drop your question in the chat box. We will be able to answer even later, even if after the session have already closed, we'll be able to answer those questions. and feel free to communicate. It's very, very, really important to work up this patient based on either you're talking about the hormones and which specific layer of the hypertrophic zone does the sleep occur. Faraj, yes. So if you go back to basic science, we have hypertrophic zones. Some books will tell you that a zone of the hypertrophic of calcification area, which is the weakest part there, because it's standing now, is still putting the calcium and is still weak in between there. That is the area that most of the time, even in the trauma, the fracture happen because it's very friable there. Yeah. I was mentioning that we should be able to really work up these patients very well in terms of, because there's many hormones that contribute in this zone, either in pleuroactive or hypertrophic zone. You can work up in terms of looking at the thyroid, how they're working. You look at the vitamin D, how they're working. Because all of these have a side effect in that area. As we mentioned from the beginning. Yeah, we're still encouraging questions. We still have like 5 minutes to go.
I think something else we ought to discuss also, it's about when a patient presents with SCIFI, is it an emergent procedure or is it an urgent procedure to take to OR?
Thank you. Yeah, that's one of the things that usually when you're talking about the sleep capital femoral epiphysis, when it's unstable, that is already falling in the categories of the emergency. It's the same, like, if somebody have a trauma, it's still, it's kind of the trauma, but in a slow phase. But now is something aggravating, make it now become acute. And in that situation, if you come overnight, of course you can. If you have a team in the place, you better take this solution and pin it. But you don't have a team in the same time, it's still okay to sleep and do it in the morning with a good team, so that you can have good radiological techs that can be able to do for you the CM shot. And this procedure, as I mentioned from the beginning, if you follow the technique very well, you can do it in just 10 minutes or 15 minutes, you are done, and to avoid the complications. So it will still fall between the agents and emergency at the same time. If it comes during the day, you do it as emergency, just go in and fix it. But if you come in the time that you think that you will not have the crew around and you will not be able to have the support from the people that are around you in terms of the x-rays, anesthesia, and the other team, then they can sleep and then you can do them tomorrow. So if you have patient that coming to you and is already in that acute and chronic situations, they're still falling on the urgent situations that, because they're now aggravating, they are not longer in their chronic situations that before. Yeah, in my hand, I usually do for the acute, I do 4 to 6 weeks of non-weight bearing, but for the chronic situation, I usually do, they go back to their situation that as they before, just to support with the crutches, and they can weight bearing as tolerated. Yeah, so capsulotomy is not one of the commonest, procedure that everyone does. Some people believe in, even if it's in the dislocation for the hip, some people believe that after you reduce, you're supposed to do the capsulotomy to relieve the intercapsular pressure that may compromise the blood supply that is coming in. It's not very common, but again, it's supposed to be very small incision. You can do from the anterior approach, the hip. You can be able to go in if you feel like it's really need to be done. And this probably will be in condition where you have acute condition, that somebody come with acute, and you may thinking there's a lot of blood bleeding inside the capsule, and it's increasing intercapsular pressure. In that situation, you can be able to do mini anterior capsular approach, and you can be able to open it and wash out that blood and be able to decompress the capsule. Yes. So if there's no more questions, I would like to close the sessions, and we'll say thank you for your time to be able to attend the sessions, and we'll welcome you for the next session that will be probably communicated later through our Kenyan Orthopedic Association for these CME sessions. Will be coming in. We'd like to appreciate all the team and all the people that were able to make this session to happen today. And thank you, Cyril, for putting also the time to be able to prepare this slide. Thank you, everyone, and we'll call it a closing for today. You can be able to just log off.